Welcome everyone. No problem. Don't leave. Don't leave. Yes, yes, you are in the right place. It's me, Pospo, and BRAINCAST for Mostly Learning. To be honest, if we were a band, we would have been, you guessed right, Simply Red from the 80s. Too obvious, right? But for the time being, we're just clinicians dressed in red. Clinicians, though, on a mission. A mission to increase awareness for encephalitis, as today happens to be the World Encephalitis Day. And these two guys here, they know a thing or two about this, right? On your left or right, I don't know, depending on how he comes up on your screen, in red, a well-known suspect, and in fact, the first guest for BRAINCAST back in the day when it was called the Psychiatry of Pandemics, Dr. Tom Pollak. Sitting on the scientific advisory panel of the Encephalitis Society, he has spent the last few years evolving our understanding of autoimmune neuropsychiatric disorders using neuroimaging and neuroimmunological methods. Alongside a neurologist, Dr. Esther Coutinho, he has set up and co-runs a joint clinic dedicated to the assessment and management of patients with confirmed or suspected autoimmune encephalitis, as well as the fresh long COVID clinic here at King's College Hospital. On your right, in, yes, red again, all the way from Liverpool, Professor Tom Solomon, the director of the National Institute for Health Research, Health Protection Research Unit in Emerging, and the next word I have to say that I had to Google how to pronounce, zoonotic infections. He is the chair of neurological science at the University of Liverpool and the Walton Center NHS Foundation Trust. When not working on, reducing the global burden of emerging neurological infections, he's just, one of us. One of us. I mean, who hasn't won 2 Guinness World Records? Yes, 2. He holds the world record in 2010 for the fastest marathon dressed as a doctor, and another one in 2014 for his sci-art project, The World's Biggest Brain. BRAINCAST people, you're in for a treat. Dr. Tom Pollak and Professor Tom Solomon. Toms, welcome to BRAINCAST.
Hello.
Hi, thanks for having us.
Fantastic. So, enkephalos, beautiful Greek word. In fact, a synthesis of 2 words, en, which means inside, and kephali, which means head. Inside the head. And what's inside the head? Well, hopefully the brain, which, despite being so well protected and tucked away within the fortress of the skull, it still does remain vulnerable, leading to all sorts of troubles, one of which is encephalitis. So, what is encephalitis?
I think this is one for me. And firstly, thanks for having us. And what a wonderful, splendid, florid, and lively introduction. I host my own podcast, the Scouse Science Podcast, and I think I'm going to learn a lesson or 2 today. So that was what did you think, Tom? What a lively introduction.
Yeah, I've got to work with guys sometimes, but yeah.
We're obviously, missing a trick, I think, up in the north. But anyway, and also, I'm very pleased that you explained the term encephalitis, because, I worked in America for a few years. And of course, there they have this dreadful term, encephalitis. And I spent many an hour discussing with them how you should pronounce the word. And of course, I go back to the Greek roots, and it's enkephalon, it's not cephalon. So I must capture you later, or edit the video just to capture that forever, because coming from a Greek person, that's definitely going to settle the argument. But what is encephalitis? So encephalitis is inflammation and swelling of the brain in its simplest terms, and we tend to think of it, some of the best descriptions, the earliest descriptions, are infectious causes like herpes simplex virus encephalitis or Japanese encephalitis. And these are, if you like, the way we have always thought of encephalitis in the past. These are viruses that get into the brain, that eat their way through the brain, they damage the nervous system. There is associated, the virus is actually inside neurons and destroying neurons. And in trying to protect the brain from this, there is an inflammatory and an immune response. So neutrophils pour in, lymphocytes pour in, and we diagnose it. If you're being very strict, it's a pathological diagnosis. So you should really only diagnose encephalitis if you've got autopsy material or brain biopsy material. There are obvious limitations in that. So we have got clinical case definitions that use clinical surrogate markers, such as seeing too many cells in the spinal fluid because they've spilled over from the brain, or seeing inflammation on brain imaging. And so those are the sort of surrogate markers of encephalitis. And what I would say is, having said, the classical viruses like Japanese encephalitis, herpes simplex virus, then came along HIV a couple of decades ago. And with HIV, it doesn't cause this florid inflammatory change, but there are subtle inflammatory changes, an upregulation of immune cells with a pro-inflammatory cytokine milieu. And I only mentioned that because I think later on we're going to be talking about the effect of COVID-19 on the brain and whether that causes encephalitis. And that's where we get into this more subtle territory. But that's encephalitis in a nutshell.
Fantastic. So immune systems gone wild, inflammation beyond control. That intimates, I would say, though, to some extent, turbulent relationship between, our brains and the immune system is certainly not something new. And there have been several theories throughout the years, several scientific reports making the link between the two of them, even way back in time. So let's do exactly that. Let's travel back in time to find the origins of encephalitis.
Okay. I think we might even go back further than your beloved Greece, although my ancient history is not so good. Mesopotamia, that's before Greece, right?
Oh,
it sounds like it. So there's a quote which Ben Michael, who's a neurologist who works with encephalitis, I think he was taught it by Nick Davies and other neurologists. It's an old Mesopotamian quote, and it's really beautiful. I'm just going to say it here. It says, "Headache roameth over the desert, blowing like the wind, standing hostile against the wayfarer, striking him like the sun. This man it hath struck, like the one with heart disease he staggered, like the one bereft of reason he is broken." And it's unattributed, we don't know who said it, but it captures so much about encephalitis. It roameth over the desert, it's infectious, it's kind of affecting all these people. It causes headache, it has this kind of, this neurological impact, but also it affects one's mental faculties, like the one bereft of reason, he's broken. And I mean, historically, I guess, encephalitis can go back as far as these pathogens have gone, right? I guess you can't really put a start to it, but people have argued that maybe Alexander the Great, another countryman of yours, maybe he died of West Nile virus encephalitis. In the stories of his death, birds were seen dying in the few days before he became unwell, and it was presumably endemic around that time at the time. And if you look at the first time that West Nile virus encephalitis hit the United States, birds got it first and began dying in large numbers before it began to affect humans. And so again, there's another story there. If you're interested in autoimmune encephalitis, some people have tried to spin a story about witchcraft and the Salem witch trials, and how these kind of outbreaks of this crazy behavior in these young women may actually have been, or at least certainly resembled a lot what we call today an NMDA receptor encephalitis. Of course, you can't prove or disprove this.
Wow, amazing. And I do remember, Tom, at some point you were talking about also the encephalitis lethargica that also has like a really long history. Is it relevant?
Yeah, absolutely. So we don't really know what caused encephalitis lethargica. It probably was around before the 1918 Spanish flu. There's stories about a similar illness called La Nona, which occurred probably in the previous century to that, and there may have been other outbreaks as well. So it certainly was a kind of encephalitis. We don't know if it was infectious or post-infectious or autoimmune, although we have some hunches that it may be autoimmune. But certainly these conditions have been with us for a while.
Amazing. All right. But you know what? Visiting the Encephalitis Society website, and for people that want to do that, just type www.encephalitis.info on your computer. So if you visit that website, one can't help but notice that one person every minute gets infected by encephalitis. So is it that common?
Yeah, so you're right that it's the Encephalitis Society website points to about one person every minute around the world being affected by encephalitis. That when you look at studies of the incidence, and we've reviewed these over the years, you typically come up with something like 5 per 100,000. Most studies will put it somewhere between 3.5 and 7.5 per 100,000 patients per year. But you know, those larger, those numbers really cover a multitude of sins, because encephalitis is not, it's one syndrome caused by either different infectious pathogens or, of course, different autoimmune etiologies. And so things vary. So for herpes simplex virus encephalitis, it's about 0.2 to 0.4 per 100,000. I spent many years working in Southeast Asia. We still have ongoing programs there, but I lived in Vietnam for a few years. And there in the summer months, the wards would fill up with children with Japanese encephalitis, and you kind of thought, this is not, you know, 3 or 4 per 100,000, and this is much more common. Wow. And in studies showed up to 50 children per 100,000 in some endemic areas. So, you know, it's a different disease in different places, but wherever you are in the world, there are causes of encephalitis, and it's an important problem.
There are estimates now that I've seen, Tom, that the frequency of autoimmune encephalitis has surpassed that of infectious. Is that something you believe, or is it due to increased recognition?
I think it's a combination of factors, and it depends also on case definitions as well. But I think we're certainly getting better at recognizing autoimmune encephalitis, and also I think increasingly not just autoimmune encephalitis where we have a particular antibody associated with it, but we now are using case definitions that don't require the detection of an antibody. So, for example, we are, as you know, we're just about to start a treatment trial of intravenous immunoglobulin in autoimmune encephalitis. And for our case definition, we're not relying on and waiting for people to have shown there are antibodies present. It's a clinical case definition that will identify most patients who have antibody plus many others who don't.
And Tom P, since you know we mentioned autoimmune encephalitis, just for people that are not really familiar with the term, can you just please give us in a nutshell what it is?
Yeah, so this is a kind of encephalitis that is thought to be caused by a sort of a misfiring immune response, where the body creates an immune response which happens to target the brain. It's frequently thought to be antibody mediated, and often these antibodies are targeting brain proteins like neurotransmitter receptors. So frequently things like the NMDA receptor, the AMPA receptor, the GABA receptor, even the dopamine receptor, along with some sort of less common receptors. But these are receptors that we know are involved in sort of mental faculties as well as sort of more basic faculties. And so as a result, these encephalitides frequently feature psychiatric symptoms really prominently, often before these patients go on to develop neurological symptoms like seizures, movement disorders, problems with their autonomic nervous system, and even coma. The other thing is that we treat them slightly differently. We treat them with medications which can either remove the antibodies or suppress their production by suppressing the immune system.
Amazing. Thank you very much. That was really clear. Now, in 2017, Luke Hoffman published an article in Brain titled Encephalitis Lethargica, 100 years after the epidemic. Now, at some point, he mentions that, whereas many cases of encephalitis lethargica likely went unreported, it is equally probable that encephalitis lethargica was overdiagnosed during the epidemic period based on the wide area of non-specific signs and lack of established diagnostic criteria. And while Luke Hoffman wrote it specifically for encephalitis lethargica, it sadly reminds me of many, many puzzling cases of other forms of encephalitis when a definite diagnosis was indeed difficult, with all relevant consequences. So my question is, are we any better in diagnosing all these different forms of encephalitis?
Well, I think Tom, raises really important points about the psychiatric features of encephalitis, and I think we are getting better at diagnosing encephalitis as a community. You're right, all of us can think back to patients that we saw, which we now recognize it probably was autoimmune encephalitis, but undiagnosed. But even the infectious causes of encephalitis, our ability to recognize them has improved over the years. So when I started my career many years ago, we would see patients who had late presentations, late diagnoses of even of herpes simplex virus encephalitis, and I was being asked constantly to look at these from a medico-legal perspective, where somebody had been diagnosed late, and was kind of getting fed up of seeing the same things all the time. And so we got some funding from NHR for a program grant to try and understand why the diagnoses were being made late and to see what we could do about it. And with herpes simplex virus, or indeed any infectious encephalitis, and to some extent the autoimmune encephalitis, but particularly for infectious, the kind of reasons why they were diagnosed late is because patients won't, if somebody has a seizure, that's straightforward. In fact, if you're going to have herpes encephalitis, please do have a seizure as soon as you can, because seizures get you into hospital. Whereas if you don't have a seizure and you just have altered behavior, strange behavior, a bit of confusion, it takes much, much longer to get into hospital. We saw cases where people were knocking on the door of the health services 7, 8, 9, 10 times. They'd had that many interactions with GPs, NHS 111, turning up in casualty. And so what people have to remember is it can be subtle. If just because somebody once has used a drug or once has had an alcoholic drink, that doesn't mean that this now explains their reason for their strange behavior. And people will take a history, they find that, okay, you know, this young person has marijuana occasionally, and then they attribute it to that. So those are the kind of errors that people make. I think not listening to the families. If the families say, you know, Johnny is not right, then you've got to take that seriously. I think misunderstanding what a febrile illness is. And if somebody has a febrile prodrome, if they've had fevers or felt unwell or hot and sweaty, then just because today, right now, when you put a thermometer into their body, they're not febrile at the moment, that does not mean it's not a febrile illness. You know, temperature does that, it goes up and down. So I think these are some of the critical things, but we've got, having recognized these problems, we've got much better at getting around them. We produced some national guidelines a few years ago, and then we studied their rollout and their introduction across many hospitals. So HSV encephalitis, in fact, we've just been looking at this. The average time to diagnosis before we started our program was 48 hours. And we know that for HSV, if you take more than 48 hours to get your diagnosis and to get onto treatment, your outcome is going to be bad. That's come down now to 10 hours. So it's improved a lot, but we've still got work to do.
Amazing.
And I would just say, from the perspective of psychiatry, that particularly we're concerned, we far more often see autoimmune encephalitis rather than infectious, although there are definitely some notable cases of infectious encephalitis who are presented just like psychiatric syndromes as well. But usually it's the autoimmune cases. And certainly in the early days of NMDA receptor encephalitis, 75% of all patients were initially seen by mental health services. That doesn't mean they all received like a mental health diagnosis, but they were at least seen by a psychiatrist or mental health nurse initially. And although that number's coming down, I think we've all got a lot of work to do to raise awareness amongst psychiatrists of this disorder. And certainly I often get a lot of pushback, by being so encephalitis centric and spotting it everywhere where it isn't necessarily, there. But, and I can think, you and I clinically, Pospo, we've often seen cases that we thought, oh, maybe this is encephalitis, and it turned out not to be. But we've also had some cases where we thought, oh no, it probably isn't, and it's turned out yes, it is. And that's how medicine works. You want to be proved wrong that this isn't encephalitis, and you want to be reassured that at least you've tested for it, and just it's that kind of awareness, and that's so essential, and that I think is often misunderstood.
Do you still do you still have patients with these kind of syndromes who are admitted and none of the team has thought, I wonder if this is autoimmune encephalitis? Does that still happen?
It does, and we are sometimes still referred patients who quite a few weeks have been languishing severely catatonic in hospitals.
Yeah. I mean, the critical thing, isn't it, for both autoimmune and the infectious is mostly at the front door of the hospital. It's the acute medics, but you just want people to think of it. That's the critical thing. If they think of it and then they decided it wasn't, even if they got it wrong, occasionally people will call it wrong. But as long as they've thought of it, then that's got to be the critical element.
But Prof, even if I didn't want to think about it, I had Tom Pollak, constantly reminding me it's impossible not to think about encephalitis when you're working with Tom. So now we certainly not go into the hard facts and details, of pharmacological management, and we would need another 2 full days just for that. But I honestly feel that, while we are pretty okay with managing the acute side of things, I wouldn't say the same about the longer-term management of encephalitis, as we do know that in some cases recovery can be slow, and the quality of life post-encephalitis can be significantly affected. In an older paper by Jesse Cooper focusing on post-hospital care of herpes simplex virus encephalitis, the team specifically highlighted the lack of support systems for the post-acute effects of encephalitis, and goes on to describe how people are consequently forced to devise their own care routines and strategies for managing their problems. So how can we improve this?
Yeah, I think that's a really good question, and I think you're absolutely right. The journey really begins when people leave the hospital and they're coming back to a life where their relationship to their own body, to their own brain is no longer what it once was. Their relationship to their family has suddenly changed. Often family members become carers that they hadn't been before. Often they aren't able to go back to a job, and there's so much to navigate there. And in reality, sometimes these patients are followed up by a neurologist for a little while and then discharged back to their GP. Very rarely do these patients get psychiatric follow-up unless they present with psychiatric symptoms, or at least unless they tell the doctor about psychiatric symptoms. We've just completed a systematic review and meta-analysis of the psychiatric symptoms that people have after encephalitis, and they're very common, and there's a huge range of them. And I think the fact is, if you don't ask about that, then these patients are likely to be suffering in silence, really. And I think there are a number of ways that we can address that. One is possibly the encephalitis clinics that we have should be multidisciplinary, and certainly in the autoimmune sphere that's happened to an extent. I know in Oxford that happens, and certainly the clinic that I run with Dr. Coutinho in London that has happened, but I'm not sure it's true all around. And so I think that kind of approach is important. Secondly, we need a bit of parity with some of the other neurological disorders. If we look at Parkinson's or MS or epilepsy, there are nurse specialists in almost every hospital who are able to coordinate the complex aspects of care. I don't think we really have that very much for encephalitis. And just from a psychiatric perspective, we need to be getting psychiatric services a little bit less afraid of dealing with patients who have organic brain problems, because the situation that even once you've identified these psychiatric problems in these patients and then you then try and get someone to see them, it's not uncommon for services to sort of be a little bit put off or scared by the fact that there's this organic problem, and either they reject the referral, they refer them on to some sort of national or tertiary service, which takes a year for the patient to be seen. So there's so much work that needs to be done.
Can I just ask, do you think, because I'm just thinking about it now, we think about, you mentioned multiple sclerosis, Parkinson's disease, those of course are seen as chronic conditions. And so therefore, we set up a chronic service. Encephalitis is thought of as an acute event. And then but people are left with long-term problems, chronic problems. But I suppose one issue is how much those kind of services should be different from other brain injuries that leave long-term chronic ill health. And I think to some extent that's where something like encephalitis falls between two stools, doesn't it? In general, services for any form of brain injury, be it traumatic or acquired, are pretty awful, I think, compared to other diagnosed distinct neurological diseases. And I wonder if that's part of the problem.
I think part of the problem is the helplessness that many services and professionals, feel about how to do things. So maybe, this shift, of focus and attitude about what encephalitis is may bring a change. But looking at the bigger picture, an older report by the European Centre for Disease Prevention and Control titled "Health Inequalities: The Financial Crisis," reminds me of really good days in Greece, and infectious diseases in Europe, it mentions encephalitis as one of the infectious diseases impacted by social determinants. So are we saying that once again, the privileged of this world are protected?
Well, I think that's an interesting thing. And I looked at the report after you sent it to us, and people should know, this is not most webinars I do. It's like turn up for a chat, but Pospo sent us our homework in advance. We had we had like a tutorial last week. So you know, this is a serious business. So I did my homework and I looked at the report, and I think the point is that, well, there are 2 points really. Firstly, encephalitis can affect anyone, anywhere, at any time, and this is one of the points the Encephalitis Society make. So in terms of who gets the disease, be it herpes simplex virus or an MDA receptor encephalitis, there's no social privileges there, particularly with those forms of encephalitis. But one critically important thing is what happens afterwards. So access to services, the types of care people get, and that's when the kind of things that Tom was talking about become so important. But there are some forms of encephalitis where there is a socioeconomic element to who gets it. And in that report, one of the things they talk about is tick-borne encephalitis virus, where this is a virus transmitted by ticks, mostly in Eastern Europe, and it's spread west. But they talked about immigrants who and people who are poor who end up going into the forests to scavenge for food, and then they're exposed to ticks, and so they become exposed to tick-borne encephalitis virus, as well as, interestingly, to other tick-borne diseases like Lyme. So that's an occupational exposure related to poverty. The other really important element to think about with things like Japanese encephalitis, which again is a disease of poverty, because even though it's transmitted by mosquitoes, and mosquitoes in Asia will bite anyone, it's the kids who are most likely to be exposed are those who don't live in air-conditioned apartments, but live in very poor housing near the swamps where the mosquitoes breed. And also those kids are far less likely to have access to the Japanese encephalitis vaccines. So those are some of the diseases where health inequalities play a role.
I see. And what would a BRAINCAST, be without a bit, just a bit, a touch of COVID, right? So Abba Ifton and Benedict Michael wrote a powerful letter to Lancet Neurology, raising awareness about the neurological consequences of the virus that's more famous than the Beatles, I have to say, the SARS-CoV-2. But although primarily a respiratory virus, it does seem to like our nervous system, with now hundreds of papers documenting its neurological and neuropsychiatric consequences. So how is encephalitis linked to COVID-19?
Yeah, I think there were lots of reasons to suspect that it might have sort of neurological consequences on the basis of previous coronavirus epidemics, on the basis of previous respiratory viral pandemics, and just on the way that we know that respiratory viruses can work in general. And sure enough, depending on how you define neurological, about a third of patients perhaps with COVID-19 do have one or other kind of neurological presentation, and then a proportion of these have encephalitis. And there's sort of different flavors of encephalitis, from sort of severe encephalopathy with seizures to more typical limbic encephalitis to acute disseminated encephalomyelitis, which is a disease which causes demyelination of neurons in the brain. And then we're even seeing autoimmune encephalitis, sometimes with antibodies that we kind of know about, like NMDA receptor, but often to as yet unidentified targets. So there's so much that we don't know. I think the one thing is that there was a lot of worry about direct viral infection of the neurons and the brain on the basis of early work. And I think that's probably, maybe Tom can correct me, turns out not to be such a massive worry, and it tends to be other mechanisms which are probably more important.
Yeah, I think you're right. So as I alluded to right at the start, this virus is not causing the sort of traditional encephalitis where a virus is eating its way through neurons, and then you've got a very strong inflammatory response to that. We very rarely detect virus in the spinal fluid, which is usually the clue that it's entered the central nervous system. And the autopsy studies that we have are a bit mixed. Most are suggesting that virus does not get into neurons. Some are saying there's virus in brain, but they're not really being clear, and it may well be in the vascular endothelium, because we think it does get into vascular endothelium and makes the blood vessels leaky, and then you get inflammation and you get edema, and so it's a rather indirect route to causing brain problems in these patients. And then, of course, you've got the long-term problems that we're seeing in patients who perhaps had a mild COVID-19 illness originally and were not hospitalized, but then they're taking weeks or even longer, months to get back to normal. And in some of these patients, there are neurological and psychiatric manifestations, as well as, so fatigue is very common, headaches common, but also this brain fog, people just feeling that they're not quite as sharp as they should be. And then as well as some frank psychiatric manifestations as well. So there's clearly, this is an evolving area and there's a lot more to do in this space.
So let's forget about COVID and let's focus on why we're all here today, dressed in bright red. Yes, it's the World Encephalitis Day.
Indeed.
So Tom S., you are the president of the Encephalitis Society that actually was the winner of the third sector awards in 2019. So what does the Encephalitis Society have in store today? I have you're turning Niagara Falls red. Is that right?
Say again, I didn't hear what you said at the end.
I said I heard that you're turning Niagara Falls red. You're lighting
we're
up
turning everything. We're turning everything red. So you're right. This is the 8th World Encephalitis Day. Ava Easton, who's the chief exec of the society, and I hatched up World Encephalitis Day back in 2016. The first one, we created the world's biggest brain made of people in Liverpool. You can search for it on YouTube. And that one, as you said, we got a Guinness World Record for that. And we've done lots of different things over the years. This year we're a bit limited by this rather nuisance of a pandemic, but we're creating red buildings all around the world. Niagara Falls, the Liver building here in Liverpool, buildings in you should follow the photos. If you look for the hashtag #Red4WED, then you'll see all the photos coming in from buildings in India, buildings in New Zealand. You know, as it becomes a nighttime, then we get a whole new host of buildings put on the website. So, but importantly, we are raising awareness about encephalitis, and it's great that you've hosted this podcast today. We had a wonderful World Encephalitis Day Alliance webinar on Saturday, and this is the 5 leading charities that work on encephalitis, including Encephalitis Society, Anti-NMDA Receptor Encephalitis, Autoimmune Encephalitis Alliance, Encephalitis 411, and HISA, which is the Hashimoto's encephalitis. So, well, what's been great this year is this real global team effort to raise awareness. And then, of course, the Encephalitis Society also supports patients and families and also encourages research. And Tom is on our scientific advisory panel, and it's a great weekend of festivities. And so it's really been fantastic to talk about this today on your podcast.
BRAINCAST people, Dr. Tom Pollak and Professor Tom Solomon, thank you so much both for shedding light in the mysteries of encephalitis, but also a massive shout out to Dr. Ava Easton, the CEO of Encephalitis Society, that dressed us all up today in the colors of the World Encephalitis Day. And from the bright reds of encephalitis to the mystical browns and beige of the Mesopotamian deserts, you can even tell how excited I am about the next BRAINCAST, and we will be, in fact, boarding a time capsule to teletransport us to the ancient kingdom of Babylon and the empire of the Assyrians, approximately 5,000 years ago, and see what our ancestors thought of, what else? The brain. With me, Dr. Moody Al-Rashid, an Assyriologist of the University of Oxford. But until then, Pospo and BRAINCAST for more learning. Over and out.
Thank you.
Bye.